Thanks very much. My name's Margaret O'Hara. I'm a founding trustee of Long COVID Support. And I'm here today with Joe House, Claire Hasty and Nikki Smith, who are also from Long COVID Support. I also happen to be patient and public involvement and research lead at University Hospitals Birmingham, and I've just had a look through the attendees, and I already know some of you from that context already, but I'm here today from Long COVID Support to talk about my experience as a patient involved in research. I got COVID at the end of March 2020, relapsed and remitted for just over a year. I had recovered, then I got COVID again, and I got long COVID again. So about Long COVID Support, we were born out of a grassroots group of people who found each other on social media and got together to try and lobby for recognition to begin with, and for research in clinics and all the things that we need. We registered as a not-for-profit company limited by guarantee in May 2021, and we're going through the Charity Commission processes at the moment. We've got 7 trustees and about 50 or so core active members. We focus on peer support, advocacy and research involvement principally. And we are a group of people who have lived experience of long COVID, but also there are medical researchers, healthcare practitioners and other interested supporters. And we cover the perspectives of not just ourselves as individuals, but also the many thousands of people who we support. And we also work with these other associated groups and other international groups as well. We've had a website since 2020, which signposts to lots of resources and information. And our main method of providing support for peer support is through the Long COVID Support Group on Facebook, which now has just over 52,000 members from over 100 countries. So we do operate internationally, even though we are a UK-based group principally, but we do have international members. We run our research involvement work mostly through the COVID-19 Research Involvement Group, which was set up in June 2020. The Long COVID Support Group was set up in May 2020, so that's 2 years. We've just had our 2nd year anniversary actually of that. The Facebook group, the Research Involvement Facebook group was intended as a space to be able to speak to academic researchers. The support group is very much for peer support, so it's very much for people with lived experience only, but we wanted a space where we could interact directly with academic investigators and innovators and whoever commercial companies, whoever was going to be doing work in this space. And it's I would encourage you to join if you're not already a member. For investigators, you can put your opportunities for involvement. You can seek people to be involved in your research. You can put opportunities for participation. You can do engagement, just come and talk about the research that you've got going on. And I want to highlight this paper by Elisa Perego and Felicity Callard. Elisa Perego coined the term long COVID. So she's based in Lombardy in Italy, and she's one of the sort of original patient advocates. This paper is a really interesting paper because it describes how it all happened, how this was facilitated by social media. And I think it's a lesson for future pandemics and even for existing illnesses. The communities are out there and they will self-assemble, even for a new virus, a whole new virus in a new world. The tools are there and people will find each other. They will self-assemble, just like if you put a beehive in your garden, the bees will come. And for any investigators who want to work in a particular disease area, it's just a matter of going out and finding these communities. On the research side, the very first paper to be published on long COVID, wasn't called long COVID at the time. I want to really highlight the date here, May the 11th, 2020. So that was pretty early on in the pandemic. This came out of a group of scientists who happened to have long COVID, who are now called the Patient-Led Research Collaborative. And they were running a group called Body Politic, which was an online peer support group operating on Slack. And it was one of the early peer support groups. And this piece of work was a survey of their members, just to survey what is this thing that we're all suffering from? What are the symptoms? They followed it up with a 7-month longitudinal follow-up. and they've actually now got funding to do citizen research. Again, they have described how this has happened and how they got to be where they are, and this is another really interesting paper. In the UK, the NIHR were pretty hot off the tracks here with a themed review, and they were speaking to us. The stakeholder engagement lead was speaking to us in summer. I remember a conversation I had with her lying on my sofa, feeling really ill. I think this is May or June 2020. And through connections through our Facebook group, she recruited people to be involved in this review. So the first one was a narrative review. The second one was a more scientific review. But because of the positive experiences that they'd had with our members, one of our members, Joe Howes, was invited to be on the steering group for that. And although it was a more scientific review, it was recognised that actually we were pretty knowledgeable about the science ourselves, and we were heavily involved in that. On the science, again, from pretty early on in the pandemic, we were seeking to speak to whoever would talk back to us, seeking to speak to scientists. And some people who are here today have been having conversations with us from early on to say, what do we need to investigate here? And this is a paper that Claire and I worked on with Nisreen Alwan. And again, it was a survey of our membership. And we've been speaking to people from ISIRIC, like Gail Carson, Janet Scott, Haritini Stavropoulou, Louise Siegfried, again from kind of summer 2020. And we developed this living systematic review. And I highlight these two. I mean, actually by now I think we've got about 30 or so papers between all of us, but it's just to highlight that we have been working in the scientific space and research space from very, very early on. And through our connections with ISIRIC and GLOPADAR, in December 2020, we had the first co-created international conference on long COVID. Because of ISIRIC's connections, they managed to get Tedros Ghebreyesus, the director of WHO, to open the conference. And he talked about the need for recognition, research, and rehabilitation. Now, that slogan was developed in our group. And to hear it repeated by the director of the WHO was really quite a moment, because it shows you how integrated we had been, and not just us, other patient groups as well, into putting long COVID on the world stage and saying, look, we really need to do something about this. So in this meeting, I talked about the need for PPI, and it was an international meeting. It's ISIRIC, they work internationally. And I really highlighted how in the UK, we are pretty good at this. And I think it is something for us to be proud of, actually. The NIHR and other organisations like the HRA and some of the charities and UKRI now, they really promote patient involvement. And I think we are kind of global leaders on this. And I was trying to say, look, this is something that we need internationally. You don't have to start from scratch. The NIHR have spent 20 years developing leadership and resourcing in PPI. We have standards, we have guidance documents. Adapt them for your settings, but please don't reinvent wheels. Let's just build on what we've got already. So through conversations that we were having with NHS England and NIHR and other lobbying, we had FOSP COVID. FOSP COVID was announced in summer 2020, and we were a bit disappointed by that because it was post-hospitalised only. And there was that narrative that it's only people that have been in hospital that will get long COVID. Now, in our groups, there was hardly anyone who'd been in hospital. Our Facebook group was growing by the minute, and it was full of people who hadn't set foot in a hospital, but still had long COVID. So we were continuing to lobby to say, look, that's not enough. Post-hospital is not enough. We need research for community cases. So the first call was announced in November 2020. And at that point, I was really keen that people with long COVID would review those calls. So the NIHR have very mature processes, even at this funding stage. For people to be involved, for lay reviewers, there's a training program, and there's a very good process for bringing people in. So I contacted the CCF, the Central Commissioning Facility. I spoke to their PPI manager, and we worked together to recruit people so that they could review. So all of these applications were reviewed by people with long COVID. And this was followed again in spring 2021 by a second call. So the first one was for 4 large projects, and the second one was for a larger number of smaller projects. And some of the investigators are here today. So, as I mentioned before, there are there's lots of guidance from NIHR. There's very clear processes. There's an expectation. Everybody knows that if you apply for an NIHR grant, you've got to do good PPI. So even though there were those processes, for the people that I was introducing to the PPI manager at the CCF, these are people who are new to PPI. You know, before they got ill, they weren't involved in research. They had never heard of patient involvement. And these were fresh eyes on the process. There were a couple of issues. We did find a couple of things that weren't quite satisfactory. So in the first call, it was frustrating for people to be told that they were limited to only commenting on the PPI section of the grant. This was a situation where some of the patients who were reviewing the grants had more publications in long COVID than the people who were applying for the grants, and some of the other scientific reviewers, because of the work that we'd been doing with you know, various other investigators. And we were actually pretty knowledgeable about the science and about the research and the wider issues. So it was a bit frustrating to be told, no, we don't want your comments on that, we just want the PPI. So in the second call, that was expanded, and the lay reviewers were allowed to comment on the whole proposal and not just the PPI section. So that was a great improvement. And this came about with, between the first and second call, with some very, very constructive conversations with the program manager and the PPI manager, which led to these improvements. So that was really welcome. In the first call, there were a certain number of lay reviewers recruited, and then you never know how many applications are going to come in, and they just got divvied up between everybody. So that felt quite onerous because there were a lot of applications, I think more than anticipated. And it felt like there were too many. So in the second one, more lay reviewers were recruited, and a limit was put on the number per reviewer that would review it. In the first call, there were only 2 patients on the actual panel itself. And that felt like that was quite onerous on them. And also there was a little bit of a power imbalance. So in the second, more patients were recruited to be on the panel. We felt with the commissioning itself, so this is post-commissioning, that these are all processes that have happened, you know, once the commission call comes out. But we feel that even before that call comes out, patients should be really heavily involved in creating that commissioned call. And in the second, there was some consultation, but I don't think it was possibly transparent enough what that was and to what extent that was. But one of the thornier issues, I've left it to last, is that with some of these applications, frankly, the PPI was not very good quality. There were situations where the LACO applicant didn't even have long COVID, where PPI had been done with general groups, again, who didn't have long COVID, where it had been done too quickly and a bit slapdash. And although the lay reviewers commented on that and said that it wasn't really that great, they were funded anyway. So it felt like PPI wasn't a deal breaker. It felt like even though you're asked, NIHR require you to do good quality PPI, you kind of don't really have to, and you might still get funded. So that felt like that's something that needs to really be addressed. So it was addressed to an extent in the second call, but I think it's an issue, and it goes beyond long COVID research as well. So, and part of the issue there is it's really difficult to get to the essence of good quality, meaningful PPI. And even though the funders might say, okay, your PPI is not great, but you can have the grant on the condition that you improve that, it kind of doesn't really work that way, because PPI is not a process-based activity, it's a principles-based activity. So you can't go and say a GCP course, a good clinical practice course, and learn how to do PPI in an afternoon. It's just not like that. It's based on trust, relationships, reciprocity. And I have to credit Sarah Knowles for this, but it has to pass the Bananarama test. It ain't what you do, it's the way that you do it. And that's actually a thornier issue. And that question of how do we know that the PPI is being done to a good quality throughout the lifetime of the grant once you've been awarded the grant is something that I think needs a bit of thought and discussion. So we've just got some recommendations from our collective experiences of being involved in this and of working with the investigators that we've worked with. We've done some really excellent exemplary involvement with some investigators, and then with others that there have been some issues that we felt aren't that good and perhaps need improvement. So we've got PPI as a deal breaker. That's something for the funders to think about. You know, to what extent should a grant be awarded if the PPI isn't good? We've got PPI mentors. Some of our members commented that they found it really beneficial to be in these panels and to be working with people who are real experts on PPI itself rather than experts in the condition. And we wonder whether there's something for the NIHR to think about in terms of perhaps lay review needs to be PPI lay review, but also expert by experience lay review as two separate items, because at the moment it all kind of gets subsumed into one. We'd like an assessment system to ensure that meaningful PPI is actually happening throughout the grant. And again, that's not an easy question to answer. We're just throwing it out there. PPI and commissioning, we would like commission calls all to be co-created, genuinely, properly co-created, so that patient priorities are addressed. PPI and funding panels, there needs to be a mechanism for power sharing, because sometimes I feel that the patient voice is maybe not as strong as it could be. Patient experts, as opposed to PPI experts, so commenting not just on the PPI section, but across the whole proposal. And public engagement, I haven't mentioned this, but we do think it's really important, more so now, and I think this is something that's come out of the pandemic. It's not enough. I think traditionally investigators will do public involvement at the end of their research, and they'll finish the research, and then when they've got some results, there's a perception that there's no point doing public engagement till you've got some results. And I think that idea is, I think it's a thing of the past now that everybody can do a Zoom webinar. We want to know what's going on. Like, you got the money a year ago, what have you done? What's happening? Is anything happening? And people really need hope, and they need to know what's in the pipeline. So I'll just leave this slide. This has got our socials on it. It's got links to our Facebook groups. And again, thank you very much to the NIHR for this opportunity for us to have this discussion. So I'll stop sharing now and I'll hand back over to Sylvia.